All right, good evening. Thank you for joining us. I'm Faye D'Souza. We do this on a regular basis when there's something new going on that we should talk about. Obviously, we have to talk about the digital health IDs. Now, this was announced and launched by the Prime Minister. It's called the Ayushman Bharat Digital Mission. Effectively, to put it in a nutshell, like you have your PAN card for everything, banking and taxation, and you have your Aadhaar card for almost everything else, you will have a health number or a health ID. Every single citizen in this country will be given one. What is the plan as it stands right now is that every procedure you have, every test you take, every X-ray that's taken will all be on the back end, loaded onto your file, linked to this ID, which can be pulled up whenever necessary. So for example, if you grew up in Delhi and then you moved to Bangalore and you went to a new doctor, your new doctor would be able to pull up your entire history of your health details from your file using this number. So that's effectively, putting it very simply, that's what it will be. There are some pilot projects that have been run in a couple of states that have apparently done fairly well. And there are some challenges also. One of the challenges is bandwidth. I mean, let's be honest, most health records involve X-rays and MRIs and complicated reports. Just moving that on the internet, we know, can be difficult and challenging. The other bigger challenge is the challenge of privacy. Can the government assure us that all of this massive data that will be stored in, let's say, an imaginary container will be strong enough? Because the government wasn't necessarily able to assure us of that when it came to Aadhaar. And when we say strong enough, will it be subject to or vulnerable to hacking? What happens if someone hacks? And it's very private data, right? It's very private information about each of us. Also, if you consider what happens when you put all of this information about 1 billion people in one place, what kind of healthcare database are you creating? And what can be done with that power? Say for someone who's researching diabetes and the movement of diabetes, to have the data, moving, updating data of every single Indian in one place is massive. That could be a good thing and a bad thing, and we'll get to that. So we're trying to understand how important this is, how it will change life for all of us, because it will, and whether it's something that, it boils down eventually to the implementation. I have fantastic guests joining me this evening. Sujatha Rao, former Union Secretary, Ministry of Health and Family Welfare, Government of India. Someone I tremendously respect, and I'm very pleased to have a conversation with her. We also have Rohin, Garg, who's the Associate Policy Counsel at the Internet Freedom Foundation. They work specifically with privacy and handling of data. And Dr. Sylvia Karpagam will join us as well. She's a public health doctor. She'll join us in a bit. I welcome my guests, and also for my audience, please feel free to use the chat window to ask questions. Let me get to Dr. Rao first. Dr. Rao, in your opinion, and you've put out a couple of tweets about this, do you see this as a positive thing? And there are obviously two parts to it. One is in theory and the other in implementation. What is your reaction right now to this health data ID?
Faye, now that we are in a very technological world, it just doesn't seem right or possible to continue to keep records in the manual form as we've been doing. It's foolish, because you have much simpler and easier ways of collecting data and storing them, which would be useful for both patient care and for keeping over a period of time without getting lost, the digitization process, portability of records, and so on. So there are lots of advantages one can think of in having a digital ID. So I'm kind of, quite positive about the development. And what I really see the utility is that patients don't have to carry huge records wherever they go. That'll all be in that little chip. And wherever they go, the doctor who's treating now cannot say, I didn't know you were doing this. He cannot pretend ignorance about not being told about a particular condition. He gets the entire case history of the person he's treating. And so the outcomes can be definitely qualitatively better. So those are the positive aspects. But then there are certain negative ones. As an opening remark, I'd like to leave it there. We will discuss it as
but please, if you want to just list out what you think the challenges will be.
The challenges will be, as you rightly put it out, 1 billion people's record being kept in one place. It can be very easily tempting to be misused. after all, privacy is not something that we've been able to get around in our country as yet. I don't know about other countries, America and all that, they're quite strict, but we still don't have a good legal framework. And we still hear about Aadhaar cards being, available in the marketplace. And there's such a breach of privacy taking place all the time. And so these records can, if you don't have your computer systems working all the time, and the broadbands working all the time, there could be places where there's no electricity. I mean, the whole infrastructure also has to be in sync with the idea of going digital. So then if you don't, it's what we see daily happening with the ration cards. Poor people are being denied their rations only because that thumb impression and the biometric doesn't sync with the Aadhaar card, doesn't sync with the ration card. And Jharkhand is full of them, and hunger deaths have taken place on account of that. So, we want to make use of this technology that is enabling very sensible and rational approaches for patient record keeping, but it has huge potential. But at the same time, our physical environment and infrastructure is not there to cope with it. So my suggestion, and I hope this government, the problem with this government is it wants everything to be done in a day. And that's where we make mistakes. So if they can go slow and steady, few cities, and build your infrastructure and the environment to it gradually, then they'll be, and take it over a period of 10 years, then I'm sure there will be much more resilience in the whole system than trying to do it very quickly. You see what happened with COVID. I mean, that was a flop and they had to give up. Government had to say walk-in is allowed. You remember, first it was only unless you get an appointment through COVID, you were not eligible for vaccination. But
Yes.
in 2-3 weeks, the government had to go back on it and say walk-in is allowed, even if you don't have a COVID registration, you please walk in and our fellows will help and do something. So, it's our inability to be able to really come up with the supportive infrastructure that will stand in the way.
And also
the privacy laws, unless and until we have very stringent legal systems, I'm afraid this will be very dangerous, because there are lots of there's a huge commercial value for this data. Let's not forget that. Huge commercial value.
Would you be able to, ma'am, give us an example of what kind of commercial data? Like we have one question that's already coming from Sylvia, which says, will health insurance guys be able to access our data, for example?
No, health insurance is only a smaller part. I'm more worried about the chemical pharmaceuticals. So, for example, you have, say, 500 people diabetic data over the country. Let's assume the universe is just 500. And the whole population diabetic data is there, Nagaland to Kerala to somewhere else. And the treatment practices, what drugs are being given. And the patient response to each drug. Now, all that put together can be massive information for a pharma company to really be able to use it and misuse it. Can you imagine all that insights that they get? And they'll buy it at a huge cost. I mean, they'll pay for it. So, for example, what is Pfizer doing today? There is enough technology and research should be done to give you lifelong immunity with this COVID vaccination, for example. But what did the Pfizer MD say? I will not do so because I earn by keeping the patient immunity only for a few months, so that you're forced to take a booster dose. Then it'll become an annual dose. That's how the business for the Pfizer company increases, right? I'm quoting him, I'm not saying it myself. Unlike polio, which once you get it, your life is protected. So, they play around with science for their commercial interest. So also over here, you don't know what kind of drug development, how this information will be used, for what, and so on. So that's why privacy is very important. And who's going to use this data and whose hands it will get to. All those firewalls need to be built. And I'm afraid that, in this madness for privatization and this scaling up everything in a day's time and the whole ideological fit of it all gives me a feeling of discomfort to say, I hope that we are not going to be compromised. Our health is not going to be compromised, because you get genetic information. You get a whole lot of information which pharma companies can then develop. I mean, I'm not saying they're evil, but they have a commercial interest. Okay, so
let's be honest about how evil pharma companies are. They're fair amount of evil, really. Right up there along with oil companies. But the question of privacy, let's take that one first, because we have a couple of experts joining us. So the question of privacy, and this is, a couple of questions that popped up. For example, Sanjay K said, will the doctor or the hospital be obliged to put my details of treatment? Will they ask me? So privacy defined really in a legal sense is the right to opt out and say, hey, you know what? I would rather not put this information out there. And for people who want to put it out there, they be allowed to do so. Rohin Garg is with us. He's a lawyer who deals with privacy on the internet. Rohin, do we understand this so far? Will I be allowed to opt out of this system if I choose to?
So thank you for having me, Faye. If I'm allowed to correct you, I think that's the issue. Privacy actually should be a bit more comprehensive. So it's not just about opting out.
Yes,
it's
please.
About who all gets to view my data. If I want to move from one service provider to another service provider, can I do that easily in a way that it doesn't put unnecessary burdens on me, on a consumer, or rather as a citizen? And I think that is where this current framework, that is one of the places where this current framework has grave issues. I think, as I think was highlighted by Sujatha ma'am, that this is digitalization in the health sector is inevitable and is necessary, right? As we saw in the aftermath of the onset of COVID, the number of teleconsultations has increased, and these things are good because we need them right now. But at the same time, in this mad rush for digitalization, that doesn't mean that, as someone actually said in a panel yesterday, we should just go ahead with this and then the sort of private sector or the medical sector will just build up these sort of regulations, which isn't necessarily happening in other sectors, and we shouldn't expect it to happen here. So if you look at other jurisdictions, like you look at Australia, if you look at the EU, a lot of these places got this sort of what is known as EHR systems, electronic health record systems, only after they had a very concrete data protection regulation. In fact, they actually recommend, there was this OECD study that actually recommended that without it, there would be grave harms for sort of information leak that would result. And I believe that's what a lot of people fear with happening with this, our own iteration of this. In fact, and I think that's one side of it. I think what the question must be asked is, in whose interest is this being done, or in the way it's being done. So again, in Australia, there was this informal survey asked of doctors and other health providers, and they said that this massive database of health records, we don't really need most of it in our daily sort of in our daily work. It may make us work slightly more efficiently, but it's not really improving healthcare outcomes in a massive way, and a lot of it is unnecessary. If that is the case, then one has to question why the government is bringing in a centralized database that stores everything, right? It's one issue is of course privacy. Sujatha ma'am has very nicely illustrated all the harms. I won't repeat that. Other is of course privacy, but in a social sense. There's a lot of details I may not want to reveal to my doctor, which may result in discriminatory practices, because I mean the Hippocrates is not binding. I mean it should be, but whatever.
So let me just rephrase, okay? Like for example, we have a question here from one of our audience members who said, Anish Korea says, will the National Health ID, government, private sector know my most intimate details, like whether or not I bought Viagra, whether or not I got pregnant, whether or not I had an abortion? Now, these are intensely personal things, right? And there is a doctor-patient confidentiality, which exists for a very specific reason, that only your doctor knows some things about you. But if the doctor is obliged to upload everything, onto one single database, and we don't know who's going to dip into it, where does that leave us? I mean, is that where we are right now? Is that what we're looking at?
That's the fear. That's the fear. There's no trust. When there's such a trust deficit situation today, I won't trust the government to be with my data, for example. So, if they build that trust, it's not safe to use these kind of technologies.
Ma'am, I found out something recently that apparently in the state of Maharashtra, at least, every doctor that does a sonography of a pregnant woman is required to upload the details of that sonography, screenshots of the sonography, the name of the woman,
Aadhaar.
and her Aadhaar to the government on a regular basis. Now, this is a huge violation of the privacy of that specific woman, because I don't know how many women actually know that this is happening. And this is done simply to prevent sex specific scanning of babies or sex selection of babies. But at the same time, there will be a lot of women who do not want to disclose.
Can you imagine abortions, for example, done by unmarried women or extramarried? Yes. All that information gets in, and you know what kind of problems. I mean, a mischievous doctor gets hold of it. What can, so you have to be very, very careful on the privacy issue, and we are not ready for that.
We also have Dr. Sylvia, who's joined us, who works extensively in public health, and I'm very glad she gave us time. There's another aspect we have to understand, which is the government tells us that this will make public healthcare more efficient and it make it work better. Dr. Sylvia, what is your opinion in this matter? Do you believe that there is a massive benefit in public healthcare by digitizing our records?
Thank you, Faye. I think the earlier two speakers have touched upon a lot of the things that I also wanted to say. I think we have like an illusion of India. Like we have a dream of India, and then there's a reality of India. And in our dreams, we want this very, high-tech, tech-savvy, smart city that's, like equivalent to the rest of the, world, something that we can boast about. And I think that illusion is something that is being built upon, but the language that is used is as though it's going to be make healthcare more comprehensive, make healthcare more affordable, more accessible. It's meant for the poor. It's clearly not, because if you look at even just the intent, I think if you look at the intent behind some of these decisions, I think what Dr. Sujatha said is very important, that there is a lack of trust. And how much can we trust that what is being put in words or in papers actually, what is the real intent of the government? And I think the COVID, it brought it in a very stark way that we cannot, if we had a limited budget, we cannot afford to be investing in something like a digital health mission when we don't have a health system itself. We don't have basic things. We don't have drugs. We don't have human resources. We don't pay people. ASHA workers across the country are protesting without basics. I mean, where is the dignity of our healthcare personnel? They don't have PPE. They don't have transport. They don't have safety. In fact, the healthcare workers who are living in some of the peripheries, they're living such a, it's a very undignified way to live. And you don't have toilets, you don't have water, you don't have public transport. So this idea that it's very difficult, like people always saying, oh, so what's wrong with, having a digital technology? It's important. But we also need to see it's not a standalone thing. And why
do you think, Dr. Sylvia, forgive me for interrupting you, do you think that this will cause exclusion? Let's assume, like is happening with our ration cards and with our Aadhaar cards, there will be someone who travels from a village in Raigad to Mumbai to go to a hospital, go to KEM, go to JJ, because that's what happens right now. Their fingerprints will not match, their health records will not be accessed, and the person then will be left without treatment. Is that a possibility?
Of course.
Yeah, absolutely. I mean, you have, the two extremes of healthcare. You have medical tourism, which definitely this digital health mission will help. You have people from across the world who will, want the best doctors, and they'll be flying in to access all this healthcare. You also have telemedicine, which, large corporates are sitting in their, cozy offices and talking to people in the peripheries. But I think what is important is that people should have access to healthcare close to where they are. And that's not happening. Like all of these systems are geared, like even whether it's a government health insurance schemes, whether it's telemedicine, the entire thing is to shift people from the villages to bring them to the cities. And the more people travel, the further they are away from their homes, it comes with a whole baggage of problems, like culturally, socially, in terms of language, in terms of out-of-pocket expenditure. And so, like, isn't this like, I mean, maybe before the pandemic, the bureaucrats could say that we didn't see it, but I mean, it's too obvious. It's right in your face. If you're even now not talking about it, then I mean, yeah, I'm very.
So let me rephrase that question. Do you believe, Dr. Sylvia, in your career in public health, that instead of addressing the problems, the glaring problems that the pandemic exposed for us, this is actually a happy distraction that's actually going to cause more chaos?
Yeah, I think it's definitely exclusionary, and it's not that we don't have evidence. We have, even with the insurance scheme, we know that people who dropped out are the people who most need these services. It is a form of exclusion, and there's no attempt to bring in those people. Healthcare has become very fragmented. There's cherry picking. You'd rather do a hysterectomy on a woman than take a woman who has cancer stage 3 and with multiple complications. People get left out. So this whole package module of healthcare system has been problematic. It has been exclusionary. And we don't have, people in the peripheries don't have access to a lot of technology. Let's be realistic about it. Like with Aadhaar and with the PDS, people are climbing trees, they're jumping around. Like there's no dignity in this whole thing. Like you want to be included in something that doesn't exist in terms of your own location. It's very exclusionary, and we don't have. So the digital technology can only be an addition to a good public health infrastructure, which we don't have.
Yeah. If you don't have the X-ray machine, what are you going to digitize and put onto your digital system? Because in most parts of rural India, they don't have basic healthcare. We know that the primary healthcare system is in disarray. We haven't bothered to fix that. Who is going to digitize anything? There's a question from Abhimanyu who says, it's been a decade since UID, which is your unique identification, Aadhaar effectively. And half the nation is in violation because they keep asking for a hard copy. Remember, Aadhaar was meant to be a number that if I go somewhere and say, I'm Faye D'Souza, they're able to use that number to verify and say, hey, yes, you are in fact Faye D'Souza. It has turned into an ID card. As soon as it turns into an ID card, it defeats its purpose because you can make copies of that ID card. You can make fakes of that ID card. Is that likely to happen here as well? And I'll take this question to Rohin. Rohin, that whole infrastructure, and I just want to point out here, so far for healthcare, we have the COVID, which we saw fall apart and then need to be bypassed. We had Arogya Setu, which is sort of a mapping app that didn't really do its job very well. We have nothing near the infrastructure of what this is supposedly going to be. Is this likely to turn into another card that people are going to make fakes of?
I think that is, again, one of the foremost fears actually that people have sort of come up with respect to this. I think there have been instances of this. So I think in Chandigarh and in Puducherry, there were orders issued at the local level in government hospitals saying that everyone or doctors who come here or everyone who enrolls here has to get has to get a universal health ID to either continue work or to receive care. Those orders were subsequently rescinded at that time, but this sort of makes clear the broader plan. Right? Everyone will get a UHID. The policy itself, the universal health ID rules, say that this is voluntary supposedly and no one will be left behind, no one will be denied services. But even if you look at the Prime Minister's statement a couple of days ago, it says that every citizen in the country will receive a health ID. If as anyone who's received the vaccine so far, a lot of initially, for example, they were asking for Aadhaar and they weren't giving people vaccines without Aadhaar. That was subsequently sort of rectified, but that danger was there. And if you see anyone who has gotten the vaccine on the basis of showing the Aadhaar card already has a UHID. I don't think most people were asked about it, but then everyone said, okay, what's this little thing on my vaccine certificate? It's my universal health ID. So that is the fear, and it's probably it's likely going to happen. Again, with AIMS, a couple of years ago, AIMS had this procedure where they would waive the registration fees of 100 rupees if one registered in the UHID program. Now, AIMS doesn't necessarily cater to the affluent classes of, the spectrum of people who come to AIMS is much wider, right? And so a lot of people from the lower end of the economic spectrum come there. And for them, waiving 100%, 100 rupees off the registration charges is huge. But that's effectively financial coercion into getting a UHID, even though they don't know the risks. They may not want to have, as Sujatha mentioned, have their data sort of captured by insurance providers, by pharma companies. So through financial methods, through bureaucratic methods, and through administration, this is going to be pushed, and it is likely that this is going to become another sort of quasi, if not Aadhaar itself, then another sort of quasi Aadhaar that hangs around all the time and is needed at every sort of healthcare incident.
Yeah, I want to take a question to Ms. Rao. This is a question from Kanchan Chera, who says, will healthcare centers and hospitals charge patients more because now they have to digitize all of this heavy information? I'm going to sort of extend that question a little more. Who's going to pay for it?
Well,
If the aim, ma'am, is to help the poor who cannot afford healthcare at all, which means the government centers have to do it. Somebody's got to pay. Private sector is going to say, hey, listen, I'm not going to pay for this. This is an extra cost. Who's going to pay for this?
Okay, so that was the third outcome of this, negative outcome of this initiative. As we said, privacy, and we said, other issues. The second is the cost of care. Cost of care is going to go up by at least 30%. There's no doubt about it, because that's what American data shows. So when you bring in computerization, it's just not only the cost of the computer, the air conditioning, and so on, but you also have to have a huge number of trained staff to do all this data filling and maintaining the data, digitization, and this and that. And in so far as the citizens are getting the ID, they may charge about 20-30 rupees per person to get that ID card. But as we saw in Aadhaar, there's so many fake cards too. So, I mean, the ability to get 1 billion people, every child born, and the child keeps changing month to month, how are they going to keep that record? Aadhaar is okay, it's a one-time record, but health is not the same. Today you have my health record, tomorrow I get TB, and the child is now one year old, becomes 20 years, So this, how does the demographic changes in the people and the population keep pace with this card system? So every time you have to keep on updating the information about the individual, and the hospitals have to maintain this whole digitized eco environment, so ecosystem. So it's not going to be cheap, and it's going to cost. Cost of care will definitely go up by at least 20-30%, and the government will typically not provide that kind of funding, and that's where it's all going to fall under between its tools. So as Rohin says, there'll be coercion or incentives to see that people adopt this new technology of having an ID card and so on. But then again, its utility and its, will be compromised because the other infrastructure elements won't be in place. So it's going to be it's not going to be easy to implement at all, because each individual has multi-ailments, multi-dimensional person to capture all that. It's not easy at all. So I kind of feel that I see the power of this technology, the utility of an ID, but that should be kept restricted to the hospitals. Let it have its own patients. So, see now today to maintain those records for 20 years is also becoming problematic. If you go to any record room, you should be able to access my 20-year-old record if I'm a patient who's been coming to you for 20 years, right? Now, keeping all that, and it's good to digitize it, it's good to do all that, that's all useful. So let only the hospital be the ecosystem where this is implemented. And even that, the government of India has been trying to get this EMR system from 2009 onwards, and we've hardly made much of a headway. So now you're going to have a national ID. It'll take them a good 20-30 years. So I don't think it's going to be.
Ms. Rao, do you expect, and we talked about exclusion, do you expect, now we have a government insurance scheme, we have public healthcare benefits that women and children access. Is that likely to be get a card, or we will not give you this anymore?
No, I don't think so. I don't think they will do that. They won't do that. But the thing is that the poor people may get a card which is not appropriately filled properly. So they may be missing data. And, you see, the whole system has to work in sync, right? He's gone to the PHC, the doctor isn't there, nurse has given some medicine, she has not filled it up in the card. So you don't know, and then she develops a reaction and she rushes to the district hospital. Now that hospital fellow doesn't have the manual thing, and it depends on this card for information, which doesn't have the data. So things like this, and in the PHC environment, the computer is not working, there's no electricity. So who's going to sit and wait for the electricity to come to fill up all the data? So the nurse will just give the medicine and say, now get on. So it's not that easy, and you'll have to maintain the manual system in parallel along with it. See, we have
so for example, ma'am, the family planning,
we have not been able to implement simple diabetes and hypertension monitoring at the ASHA and the A&M level for the last how many years? I think 5 years since they started this A&M tablet and this and that. So it's enormously difficult to do this program. But as I said, it has huge technological advantages, and I think it should be facility-based, and incentives should be given for facilities to try and get more and more into the system so that over 30, 40 years, we do get into this.
Ms. Rao, what is your assessment of the pilot projects that have happened in 2 states so far? Have we done enough of a pilot?
I'm not aware of the pilot projects. Were they successful? Has anyone?
Well, we understand this is the information we have, that 1 lakh cards were handed out.
Anyone, because Mr. Arish Sharma is so positive and he never sees any fault in what he does, so I can't go by him. I want a third party evaluation done, and they should be able to tell what are the goods and the bads about this. The bads may be more financing is required, more staff is required, more, this kind of a thing. See, when you are at a level, the drug, for example, in the Government of India laid a policy that all drugs dispensed at right down to the sub-center level. As you know, in the hierarchy of government facilities, sub-center is the lowest, and the primary healthcare is for every 1,000 population. Yet every drug that is dispensed must be computerized and sent on that very day. Now, what has happened with that? That is, the pharmacist is the only fellow, because there's one doctor, there's a nurse, and there's a pharmacist. So it's a pharmacist who has to give the drugs, and he has to fill in this data, and the computer program hangs. There's so many problems. You go to any PHC, you will find them with a bucket of complaints about how much of workload has been added on. So if you want this digitization and this filling in the cards and updating them, you need to put in more people. So as Sylvia has rightly said, here you don't have doctors, you don't have basic health infrastructure, and now you're going to divert the whole health teams into this digitization and giving ID cards. And the way they did in the middle of a COVID, everybody was more busy with the COVID rather than trying to do tracing and treating. So, this is not the time to divert your attention to great ideas. But the idea is good. I have no quarrel with the idea.
So let me just share with you, Ms. Rao, the information we have been given by the government so far on the pilot project. It basically just says that 1 lakh health IDs were created under this mission in 6 states and union territories on a pilot basis starting the 15th of August this year. So just now,
this scheme, typically in any civilized country or any developed country, what they would do? They'll run the scheme for 3 years. And they do it also on a randomized trial basis, in the sense without any support, with support, so that you understand which are the variables that make it successful and which variables are required. What are the gaps that they need the policy? So let Mr. Arish Sharma run this for the next 3-4 years, and then let us get into a national thing. Just by giving cards to 1 lakh people, any Joe can give it, even you can give it. That's not a problem. So that's not the way you do pilots. Pilot means you have to actually implement it over a period of time and then see what happened. When that one single doctor was on leave for 1 month, what happened to the patient? Who and where and how was that? The synchronization between all the referrals or all the facilities, between public and private, they're building the entire health ecosystem. It's not easy. And it's very good they've taken 2 districts, let them implement it there. That has been my recommendation to the government of Andhra Pradesh today, saying let's take 1 district and implement it and see what are the lessons to be learned before you scale it up. But in the typical fashion, I'm very frightened that the government of India would say, no, the whole country has to be done immediately. And then nothing will come out of it.
Dr. Sylvia, the question that and unfortunately I keep coming back to privacy specifically of women, because so much of healthcare, especially with women, it's women who are perhaps not disclosing everything to family members. So much is hinged on privacy. For example, the fact that women across our country get free family planning aid from government. They get birth control pills, they get access to abortions, they get access to various other things. Is there a likelihood that that might also be part of the exclusions, that they might be a privacy risk? Because we don't know who's handling this data. Like Ms. Rao told us, we don't have laws right now about our privacy.
I think the thing we also need to talk about is one is the ethics of individual doctors, but also the ethics of the healthcare system as a whole. And I think there's huge gaps in that. So, for example, we know that even before this, like patients have been subjected to clinical trials. There's been, there's been research conducted, and decisions have been made based on what like the corporates want, or say the pharma company wants. So say example, they have access to this data. They can say that a lot of women prefer XYZ things, or a lot of children are having these XYZ symptoms. Therefore, you need to have these vaccines in place or these kind of drugs in place. The ethics of that whole thing. And what you're saying is true, because doctors are already complaining that they are overworked. And now you're giving them this additional responsibility, which they may not do. They might give it, hand it over to someone else who's going to be entering this confidential data into the system finally at the end of the day. And are doctors really going to be honest in, talking about the things they do? Because clearly the practice is not ethical. Like they are doing cuts and commissions, they're doing unnecessary treatments, they are referring patients to their friends, they're getting commissions out of that. They are prescribing drugs. Like there was a time they were asked to prescribe generic drugs, that fell through. Patients used to tell us that they write the generic drug, but then they tell us we don't guarantee that this will work, and they give us another prescription to a specific pharmacy and say you get this branded drug. So if it's not like this data is going to be honest. It's not like this data is going to be reliable, because the system itself is not ethical or reliable in many ways, in many instances. And also they've said that it should be optional. So in terms of data, we already have very little data in terms of specifically the private sector. What is a morbidity? What is a mortality? How many hysterectomies are they doing? Are they really mandated? So I'm saying that ethics, of course, it has a personal level, and if that's not there, then these kind of systems will further aggravate those issues.
Do you think, Dr. Sylvia, that there is a possibility that this amount of big data collected in our country of every single diabetic per patient in India, which is the biggest database in the world, so on and so forth, will actually help advances in medical science?
I mean, it can technically, but going by what's been happening till now, I don't think so. I think it can be misused sometimes even against the patients. The kind of recommendations that are made using this data. So this data can actually become a way of selling something, as evidence. Like you have a lot of these large multinationals like, coming into India and doing research using even existing data, but they use that data to push their own corporate agenda. Like they might have a questionnaire which says, what is your feedback about the system? And then they might say people are saying they're not happy with the public hospitals, so maybe public hospitals should be shut down. So there's a lot of room for abuse of this data, purely because of lack of regulation, and also because of the intent. Like if corporates are going to get this data, then how is it going to be, abused by them against the people who it's intended to, they say it's meant for the people, they say it's meant for the poor, but we can't just, hand over the data based on those things. There need to be a lot of checks and balances and a lot of systems in place, which we clearly don't have.
It can be definitely a perverse use of the data. Instead of a beneficial drug, they can develop a drug that will make them dependent on, something like that Montano, what are those seeds that they did?
Monsanto?
Yes.
Monsanto, yeah.
It's good
Yes.
in but has its own side effects. So those kind of things can also happen. So that's the reason why, what Rohin has been emphasizing, the privacy of the data, to whom are you giving? Pharmaceutical companies must not get it, but it must be available for research and drug development by responsible, because this is wonderful, valuable data, it's extremely valuable. So you can do definitely excellent drug development, but then those agencies should be accredited. Do we have all the systems in our country, really?
No, it is said that data is the new oil. And remember when, there are many countries in the world who got very rich because they had oil reserves. We have data because of sheer numbers of the people that we have. So that's something that we need to be careful about.
After us for that. That's the main point.
So, Rohin, I have this question for you. We're actually in the middle of a almost comical crisis where those of us who are required to file our IT returns are not able to do so because the system on which we're supposed to file it has too many bugs in it. And we have the finance minister regularly calling out Infosys for designing a shoddy system. When simple, almost paperwork cannot be processed, the idea that a system like this is being designed where denial or exclusion could be a question of life or death is really scary. In your opinion, has the Indian government and all of its agencies displayed an ability for understanding of privacy, for understanding of the structures of the internet, of digitization, enough to be able to implement something of this size?
Thank you for framing in such a pointed way. But no, the obvious answer is no, because as with the income tax returns, this is what comes from implementing something in haste without actually having proper systems to ensure that that what you're implementing itself functions smoothly. One key thing I think that is not spoken about as much is that authentication for health IDs will be done through Aadhaar. Now, that means all the issues that you had for Aadhaar will be ported onto this, right? And I think in 2019, there was a presentation by the erstwhile CEO of Aadhaar which said that the all India average for Aadhaar authentication failures is 12%. For a country like India, that's a massive figure, and that is an all India average. So one presumes that in urban areas like Delhi, Bombay, Calcutta, these numbers won't be too high. In rural areas, the mufassals, I can only imagine the sort of calamity that occurs. And so, in the midst of all this, in the midst of a country that arguably isn't even digitalizing fast enough in terms of infrastructure, but in which digital literacy is abysmal, to assume that people will be able to navigate this effectively and in a way that protects their interests, I think is a huge leap of faith at best and a cynical ploy to put it in favor of the
I just want to, with the panel's permission, point out one more thing. As Shell D has pointed out, this is ironic given India's usage of internet blackouts, which India resorts to on a regular basis. In the year 2020, India saw the highest number of internet shutdowns in the world, where we've used internet shutdowns to basically manage law and order. In fact, it's so ridiculous that just this week, the state of Rajasthan shut down the internet for 12 hours for everybody because there was a teacher's entrance exam that was taking place and they didn't want people to cheat. I mean, imagine your doctor not being able to access your health file for 12 hours because someone was taking an exam somewhere and they've shut the internet down for the whole state. Doesn't matter who you are, how much money you have, which fancy hospital you're in, you will be shut down for everybody. So it is ironic that we hinge everything on the idea of digital and then we take it away with no explanation. I mean, it's a ridiculous violation of human rights. This is something.
If I may,
yes.
Sorry. So I think, and this is something that the pandemic should have taught us adequately. there is a lot of value to efficiency, but the main principle for any governance system, arguably any system, should be resilience, right? To be able to look at threats, ensure that the main users, in this case, the citizens of India, are served properly. And if you, in this sort of drive towards sort of hyper efficiency, and arguably not even that, this is what gets lost. And of course, as you mentioned, you have a shutdown, and it may be the case that, oh, sorry, I'm your doctor, but I can't sort of verify your Aadhaar, or I can't verify your digital ID. Please come back the next day. And that's obviously terrible.
Ms. Rao?
Yeah.
Internet shutdowns and the use of...
I mean, those are very, very real. And, you don't have to wait for a shutdown. There's no power in in several parts of the country. So why, even in Hyderabad, which is such a huge happening place, there's a bit of a rainfall and there's a power cut and I can't access my computer. So, I mean, that's what I said in my opening remarks, that you may like all these ideas of modernization and digitization and technology, but you do have to develop the ecosystem and the infrastructure, supportive infrastructure that has to be accompanied with that, which means heavy investments, and if you're going to be handing over much of your entire bandwidth and your entire telecom into private hands, that's another thing also. I mean, I'm not saying it's wrong, but I'm just saying then you have to build very strong legal systems. US has a lot of private sector, but US has very strong laws and a very strong Supreme Court. The judicial system here, where do you go? I mean, it's all a hassle from day one. Which patient's problem will anybody listen to? So I think it's a good idea, but I have a feeling they should spend time on working out at a district level, then a regional level, then a state level, and work and go slow and build the system alongside rather than rushing.
Let's also be clear about the fact that not only is our internet and all of the data that goes back and forth on the internet in the hands of the private sector, the back end of it is in the hands of China. So it's not even as simple as, just us. Who do you think makes the routers? Who do you think makes all the hardware for all the phones that all of us use? It's China. So to be loading more and more into this and to not have, I want to remind our audience when the Supreme Court asked the architects of Aadhaar how they're going to keep the data safe, they said we have a 12-foot wall built around the center. I mean, this is ridiculous. You've not displayed the ability to be able to do this right. The least the government should do is pilot it for maybe one small piece of the population, see if you're able to do it well.
Saying on the one hand that you won't allow China to compete for 5G, and on the other hand, you're going to hand it all over on a platter to them. Because they have it's a very tricky thing. And that's the reason why world over, the EMR isn't so, centralized and done the way in which our ambition seems to be driving us. There are a lot of risks involved.
The other thing that concerns me greatly is that this announcement was made and mainstream media didn't really question any of it.
Madam, your mainstream media doesn't question many things. This is the simplest, So I think we should not worry about mainstream media, but we certainly need people like Rohin and others, lawyers, to look at this whole thing in a very strict legal sense and take it up to the court. I find today the only one who can bring some accountability in the government is the Supreme Court, and some clarity in their programs is the Supreme Court, as we found in the vaccine program, So I think this requires that. Media, nobody has any more hope with. So, that's just...
That's a pity. Because
for us today.
Can I make a point?
Yes, Doc, go ahead.
I think we have, we were talking about the internet blackouts. I think we saw that, like, as a healthcare professionals, we saw what was happening in Kashmir. Like during the COVID pandemic, it actually affected people's lives. It actually affected people's access to healthcare. People couldn't call their blood banks. Pregnant women didn't know which hospital to go to. So it was like a huge consequence, not, in terms of actual morbidity and mortality. People actually died because of, lack of access to, basic even internet connection. So it also becomes a way of the government controlling its people. They switch off when they want and they switch on when they want. So yeah, I just want to add that point.
Thank you so much. We're going to leave it here, but I promise the audience one thing. We will continue to talk about it, because even though Ms. Rao has said that nobody has any hope from the media, I believe the media has a responsibility here to caution citizens of the various pitfalls, the benefits and the pitfall of every single government policy. That's the job. So when tomorrow you are asked, shall we sign you up for a health ID? You know what you're getting into. You're able to make that decision because you are better informed. That's my job. And I do hope that the audience will share this video with whoever you can, so that more people can get better informed about what's going on. We'll have more conversations about this as well. The news is up at exactly 9 o'clock. Thank you so much for watching. Thank you to my panelists as well for giving us your time.
Thank you.